This episode was recorded in Q1 2026. The information provided in this podcast is for educational and informational purposes only. The views and opinions expressed by hosts and their guests are their own and do not necessarily reflect those of the Irish College of GPs. By listening to this podcast, you acknowledge that no party is liable for any direct or indirect consequences resulting from the use of the information provided. More information can be found in the show notes or at irishcollegeofgps.ie.
There's quite a big overlap between heart failure and type 2 diabetes, and this is maybe something which is less publicised than the likes of type 2 diabetes and atherosclerotic cardiovascular disease. So diabetes is a risk factor for developing heart failure in the future, and having diabetes puts a person at twofold increased risk of developing heart failure in the future.
Hello and a very warm welcome to the GP podcast from the Irish College of GPs with me, Dr. John Maher. Today I'm continuing my conversation with Dr. Lisa Devine, lead author of the Irish College of GPs Type 2 Diabetes GPU, published in November 2025 as part of April CDM month. If you haven't had a chance to listen to part 1 yet, please pause this episode, go back to part 1 which is already available in the show feed, then return here to continue the conversation. Topics covered today include pharmacological options in type 2 diabetes with a focus on individualising therapies, managing other cardiovascular risk factors, potential complications and audit opportunities. As usual, I'll include chapter markers and links in the show notes. So, Lisa, you advise in the GPU that we should no longer refer to diabetic patients, but rather to patients living with diabetes. Could you begin today's episode by telling me why this language matters?
Yeah, absolutely, John. So your language is fantastic this morning. And I suppose chronic disease management, or we should probably call it chronic condition management, is evolving all the time. But one of the things that we know is we want to bring our patients along with us as empowered partners. And a very simple thing that we can do in practice that costs us no time whatsoever is just consider the language that we're using when we're talking to people. And there is this fantastic worldwide language matters movement going on at the moment. And it really just asks us to consider very simple swaps in language. So moving away from words such as diabetic patient and moving towards language like a person living with diabetes. And I suppose when we use this type of empowering language, it really puts the person at the centre of their care and not the disease. So we'll pull up a couple as we go through. We'll try to use our patient-friendly language, but as we know, nobody's perfect with these things as well. So we can all slip up from time to time, but a little move in the right direction is fantastic.
Agreed. And as you mentioned in part 1, one of the big changes in conceptualising management of diabetes care is in individualising therapies to the patient in front of you. And that's what we're going to move on to at this point, Lisa, which is on page 7 of the General Practice Update. And again, it's one of the quick links too, and that's individualising therapy. So perhaps you could walk me through that process, please.
Yes, I suppose we'd be remiss if we didn't start this by just giving one sentence in on metformin, because that's a very common question that people ask me nowadays is, does metformin still have a place in care? And in fact, the guidelines would say that metformin is still a first-line management option for many people living with type 2 diabetes, along with lifestyle advice and structured diabetes management and education. Now, either alone, metformin alone, or metformin in combination with other treatments. Will it be the case in 10 years? I don't know. We'll have to see. But at the moment, metformin still definitely has a place at the table. But there is a big shift now towards individualising the pharmacological management options based on the patient priorities. Now, these are priorities that we want to keep an eye out for. And they're often priorities that the person living with the condition will actually bring to us themselves. So some of the key priorities that we'd be thinking of would be, is this a person with type 2 diabetes who needs cardiorenal protection? Is this a person with type 2 diabetes who is living with overweight or obesity? Or is this a person with type 2 diabetes where frailty is really the overarching priority? And then based on those priorities, we can kind of try to match up the best treatment that's going to be of most benefit to them.
So again, referring to page 7, Lisa, of the general practice update, you actually specify in terms of cardiorenal and organ protection the paradigm shift that's occurred in the world of type 2 diabetes, where organ protection and cardiorenal protection is kind of an independent risk that we should be considering separate to glycemic control.
Yeah, absolutely. So we spoke briefly in the first episode about how diabetes management has changed, which is fantastic, although it can make it a little bit more complex for us. And one of the big shifts is this whole idea of cardiorenal protection. And in a nutshell, that's really that we have discovered that certain classes of diabetes medications, namely the GLP-1s and the SGLT2s, have been found to carry additional patient benefits beyond simply their effect on glycemic control. So we're moving away from that glucose-centric kind of approach and really looking at the person. And one of the first things that I would think if I'm seeing somebody in practice is this a person with type 2 diabetes, and are they living with another kind of priority? So that there would be certain groups who may benefit from the addition of cardiorenal protection. And there would be 4 main groups there. So that would be a person with type 2 diabetes who is also living with atherosclerotic cardiovascular disease, a person with type 2 diabetes who doesn't have atherosclerotic cardiovascular disease, but may be at high risk of that because they have several other cardiovascular risk factors, a person with type 2 diabetes who's also living with heart failure, or a person with type 2 diabetes who's also living with chronic kidney disease. And we won't go through it in detail because, of course, the GPU is readily available. But over those kind of pages, page 7, 8, 9, and I think 10 as well, 7, 8, and 9 actually, it really goes through the approaches for those specific groups of people. But essentially, it's the addition of one of those medications, either to add additional glycemic control, or in fact, to add cardiorenal protection in the same way as we would a statin. So you might well have a person where they have type 2 diabetes, their glycemic control is actually pretty good, but you might add in something like a GLP-1 or an SGLT2 to get that cardiorenal protection. So I suppose that's just a new way of thinking about things a little bit. The other thing to mention about the GPU is in the algorithm, it also gives you a little signpost to what medications not to add in these groups. So for example, if you have a person who has type 2 diabetes and they have heart failure, you would be looking to avoid the likes of pioglitazone. So that's just also worth a mention, and that's all covered within the GPU.
And quite rightly, as you said, Lisa, we're not going to try and cover all our bases in this forum because the general practice update is there for that purpose. But one little nugget that stood out to me in terms of who to consider was the fact that the bar is reasonably low, really, because in terms of high risk, if somebody's over the age of 55 and has 2 other risk factors, that would be sufficient. And the risk factors would include hypertension, smoking history, and hyperlipidemia. So anybody with that kind of metabolic profile is likely going to need consideration, and then possibly the SGLT2 or the GLP-1. So as I said, on CDM reviews, it's probably worth our while, isn't it, keeping our threshold low for at least considering those additional agents?
Yeah, absolutely. So I do think, as you have pointed out quite rightly there, John, a large amount of the people that we see with type 2 diabetes will actually have some of those risk factors. And so it's always worth just keeping in the back of our heads. And, we'll mention just briefly the new NICE guideline, which has just been published, where they talk a lot about adding these medications in for a lot more people. So we'll mention that briefly at the end. But I think you're absolutely right. There's an awful lot of our people who are living with type 2 diabetes who may benefit from the addition of cardiorenal protection.
So that's pages 7, 8, and 9 on cardiorenal and organ protection, Lisa. And then the next subgroup that you mentioned was how to choose medications where weight management and obesity is a priority.
Yeah, so I suppose In practice, this is certainly something that we see very commonly in people living with type 2 diabetes. And while it's really important that we're very sensitive in the way that we speak about weight with all people, I find that this is actually often a key priority that the person living with diabetes will actually bring to me as much as I would ask permission to bring it to them. And we know that weight loss in people living with type 2 diabetes or at risk of type 2 diabetes carries many benefits, including delay of progression from pre-diabetes to diabetes, improved glycemic control, improved cardiovascular and metabolic health. So it's really a very beneficial area for to address in the consultation. Now we know that weight management both within and outside of type 2 diabetes is holistic. But just speaking about the medication piece, there's two bits that I'd like to draw attention to. The first is it's always worthwhile keeping an eye out on the person's medication list for any medications they might be taking, both for diabetes and other conditions, which could actually be weight promoting medications. So medications that add weight as opposed to reduce weight. So there are some diabetes medications which can cause weight gain. These would include pioglitazone, the sulfonylureas and insulin can all actually cause weight gain in people living with type 2 diabetes, so we need to be aware of that. But equally on the other side, if we're picking medication for people living with type 2 diabetes, and if they're also living with obesity or if weight management is the key priority, some of our diabetes medications can help with that. Metformin has been associated with a very small amount of weight loss, although it's not massive. With SGLT2 inhibitors, you can also get some weight loss of a couple of kilos. So often they can be of benefit, but probably the more potent, the most potent medications within these categories would be the GLP-1s. And it is worth having a little look at the algorithm there for the GPU, because it does kind of go through the different potencies of the medication. Obviously, with the likes of semaglutide and tirzepatide being the most potent. And then in the middle, we have the likes of dulaglutide. And then kind of at the bottom there, you have more of your metformin, which has very little weight loss, but some little bit of weight loss, and your SGLT2. So I suppose they are the medications that carry that additional benefit of weight loss. Now, John, before we came on air there, you quite rightly were asking about the other intervention that can be considered, which is that whole area of bariatric surgery. And you're absolutely right. Bariatric surgery is a key treatment option for people living with type 2 diabetes and obesity. Of course, access and availability is the challenge there. But a referral on to the weight management clinic is something that we should keep in mind, because that is where a holistic, a very comprehensive holistic assessment can be carried out. And one of the options that they have available to them would be consideration of bariatric surgery.
It's interesting, Lisa, that you mentioned that oftentimes patients will come to you with the weight loss issue these days rather than the other way around, and trying to, tactfully bring it up during the consultation. And I just wonder whether the advent of the GLP-1s has had something to do with that, because it's so prominent in the public domain now that people know these medications are available and that they can hope to achieve weight loss, that there's a medication that can help, that it isn't all about their choices and their, in inverted commas, wrong choices.
Yeah, I mean, I think that day where, we felt it was eat less and move more, that day is long, long gone. We know, I suppose when you talk to people about weight, it's really important that we are sensitive to how difficult the issue is. We will often have people who are coming in that might be eating better than you or I, getting to, doing all of the right things better than you or I are doing, and are still really struggling. So, pharmacological therapies are really important. I think one of the benefits for people who are living with type 2 diabetes is actually most of these therapies are funded, which isn't the case for people who are not living with type 2 diabetes. So semaglutide, dulaglutide, all of those GLP-1s are available. They are funded for people living with type 2 diabetes. As we go to air today, tirzepatide is currently not funded, although we have to wait and see what happens with that. Liraglutide, the diabetes branded medication, liraglutide has also gone off the market. It's not available anymore, so that's also probably just worthwhile. But I suppose that is one less barrier for people who are living with type 2 diabetes and obesity.
And then the final subset, Lisa, that you mentioned was the medication choice for those where frailty is a key priority.
Yes, I suppose this is an area which is becoming much more, I suppose we're gathering more and more awareness of this whole area of frailty in type 2 diabetes. And we know that we have an aging population in Ireland, and we have more people who are living with multimorbidity and frailty. And in the same way as we might say, is the key priority for this person living with type 2 diabetes, is it cardiorenal protection? Is it overweight or obesity? We might also ask ourselves the question, actually, is it frailty? Is this a frail person living with type 2 diabetes? And how does that change my approach? And we mentioned in the last episode, just making sure that we have the appropriate glycemic target selected. So making sure that we have the right glycemic target for our person who's living with frailty is one thing that we can do, which is really positive. But then if frailty is the key priority, it does affect a little bit our medication choices. So we want to, in particular, avoid medications that would put a person at risk of hypoglycemia. So that would be your sulfonylureas, and insulin is the other, that's the other medication that carries the highest risk of hypoglycemia. So trying to avoid where possible these medications. And then our first line medications for people living with type 2 diabetes where frailty is the key priority would be the likes of metformin at the lowest possible dose as your first line. And then if that isn't suitable for the person for any reason, a DPP-4 inhibitor, either as your alternative first line or as your second line therapy. And then I guess when we get down the way towards the likes of your SGLT2 inhibitors, you're really balancing things up there a little bit. So you want to balance the benefits of kind of glycemic control and all of those things versus the potential negatives for that person of mycotic genital infections, hypotension, all of that kind of thing. So you're really kind of, I suppose, balancing risks and benefits. And then considering, when it comes to the GLP-1 receptor agonists, you really have to be cautious where frailty is the key priority. Our GLP-1s can obviously cause people to have GI symptoms and a reduced appetite. And if a person is living with frailty, those side effects could cause significant harm, which would outweigh the benefits of adding in the medications there. What can be tricky for us, I suppose, is very often you might have a frail person who's also living with chronic kidney disease or heart failure. And that's where we can have a look at things in terms of what's the key priority here, really individualize the care. And that's also, I suppose, where we can look at getting an opinion from our colleagues, either in the hubs or secondary care if we're struggling.
You mentioned metformin at the lowest dose possible as a suitable first-line therapy in this cohort. And I know, oftentimes the glycemic target is a little bit higher for older patients as well. So when you say at the lowest dose possible, like would a low dose once a day suffice there potentially, or am I being overly didactic or prescriptive?
No, not at all. I suppose you can individualize it a little bit, but you're probably looking more towards your 500 once a day or your 500 twice a day. The other thing to consider about metformin, I suppose, is there is an association between metformin and vitamin B12 deficiency. And our older adult cohort are a little bit more at risk of that as well. So if we can keep to the lower doses, if you speak to older people who are taking metformin, you will find that there's a relatively high presence of GI side effects as well. So I suppose one thing would be to keep in mind deprescribing opportunities. So say if you see an older adult, their HbA1c is 46 and they're on metformin 1 gram twice a day, but you speak to them and their appetite is poor, bringing that down, maybe halving the dose, see how they get on. So I suppose keeping an eye out for those deprescribing opportunities is important.
Yeah, it's a nice one to remember, isn't it, Lisa? To maybe ease off the throttle. There is such thing as overly tight control as well, and into deprescribing to kind of keep that as a focus too. So that's a nice pearl. I'm still on page 10 of the general practice update, Lisa, and the final cohort then we have is what you might say is the most straightforward cohort, and that's patient groups who simply need glycemic control.
Yeah, so it's interesting because I suspect that in the last 3 groups that we've covered, we've probably got most of the population. But of course, you might come across the odd person who doesn't have any of those factors as a priority that we've just discussed. And I suppose my thoughts on that would be in kind of what we wrote about in the GPU is considering the fact that in those patients, really all of the different medication classes are available to us. And one other factor that we might like to consider in those patients is the potency of the medication that we need. So what is the level of the HbA1c and what potency of medication is needed? It's probably worth just highlighting as well, and we certainly won't go through it in the podcast today, but we do have an extensive medication safety chart in the GPU, which just goes through kind of key prescribing points. And we have a shorter chart as well, just going through kind of the pros and cons of all of the different medication classes in the GPU as well. So the short version is on page 11 and the long version is in the appendix. So it's just worth noting that is there as a resource for people. Listen, I think as GPs, a lot of people have much of this information in their heads already, but sometimes it's nice just to have a reference point.
Thanks for that overview of the different the different factors that we should consider when deciding on that individualized, tailored program for the patient in front of us, Lisa. And of course, your general practice update, which is a synthesis of the available evidence, was published at the end of last year in November. And since then, a new guideline has been published by NICE very recently. And are there any differences there that you'd like to mention to listeners?
Yeah. So the first thing, John, thank you just for clarifying what the GPU is, because of course it's different to a guideline. So the general practice updates are they're a synthesis of the evidence. They're an educational resource and they're based on what information was available at the time of publishing. We spoke about in the first episode about how writing the GPU was a little bit like running alongside a moving train, because the world of diabetes is changing so much and so quickly as well. The NICE guideline, I suppose it is a guideline. It goes through an entirely separate process and it takes into account many different factors for UK healthcare practitioners. So they take into account clinical evidence, but also other factors from their healthcare ecosystem. Now, it is a very interesting document, and it probably is worth noting some of the key differences and some of the key new things that they have done. But it is also worth noting that it will be interesting to see what's published from other sources, from other ecosystems as well in the coming months and years. But I suppose some of the things, so much like us, NICE identified people living with type 2 diabetes and frailty as a key group. So that was fantastic to see that they had also identified that. And they have also given some recommendations that are not exactly what would have been included in our synthesis of the evidence from November, but not too dissimilar either. They also included people with early onset type 2 diabetes as their own separate group. And I think that was very forward thinking of them. It is worth noting that if we in the Republic of Ireland have a person with new type 2 diabetes, under the age of 40, it is recommended that we refer them on for specialist input. So either to the hub or to the hospital clinic, because these, they're a complex group of people who need early aggressive management. So they do need some specialist input. And certainly we acknowledge that over here. One of, I suppose, the interesting recommendations that NICE have made in their new guideline is they're recommending putting all people with type 2 diabetes except those living with frailty on dual therapy from the get-go with metformin and an SGLT2 inhibitor. So that is a real change in practice. And again, we should note that this is a guideline that is specific to the UK healthcare system, and it matches their ecosystem. So what I will be really interested to see is what other guidelines are published in the coming year. But I imagine our listeners are probably wondering about that. And so it's worth mentioning. It's worth mentioning it today briefly.
Before we move on from glycemic agents, Lisa, we haven't mentioned insulin yet. And perhaps you'd like to just briefly give me an overview of where that sits now.
Yeah, so I suppose despite all of the other treatment options which are available, we know that some people with type 2 diabetes will end up on insulin. Now, general practice has done a fantastic job through the chronic disease management program at taking pressure off the hospital system. So we know now that 95% of people who have type 2 diabetes who are attending the CDM program are only cared for by their GP practice teams now, which is fantastic. For the common, everyday working GP, there is no expectation that, of taking on the management of insulin, and the model of care for type 2 diabetes is quite clear that this is a group of people who are looked after at what they call level 3, which is hospital outpatient level. If a person has type 2 diabetes and their glycemic control is really off target, and we're kind of coming to the end of our options, we can refer them onto the hub, and the hubs will often initiate insulin for appropriate patients, and then they can go on to hospital outpatients.
So that's the glycemic agents, Lisa. And then when it comes to management of other cardiovascular risk factors and performing a cardiovascular risk assessment on those living with type 2 diabetes, you have a section on page 12 which goes into the particulars of hypertension management and hyperlipidemia management. And of course, Dave McConaughey and Eamon O'Shea have already produced episodes on each of those. So we may not labour the point this morning on this forum, but again, all that information is in the General Practice Update on page 12 for those who'd like a quick refresher. And then the next thing that you mentioned, which is always a useful reminder, is around aspirin.
So yeah, you're absolutely right, John. And we've spoken a lot about the holistic management of type 2 diabetes this morning. When it comes to prevention of the macrovascular complications of type 2 diabetes, such as preventing atherosclerotic cardiovascular disease, so things like heart attack and stroke, in fact, managing cardiovascular risk factors such as blood pressure, lipids, and promoting smoking cessation are hugely important. And as you've said there, we do have, this is bread and butter GP stuff. And our colleagues know a huge amount about this already. And as you've said, there is a quick reminder on that in the appendix in the GPU. It is worth noting that aspirin is not a recommended treatment for primary prevention in people living with type 2 diabetes. So it is just worth highlighting that because that's a common question.
Okay, Lisa. Well, from my own perspective, conceptualizing the different risk factors is certainly helpful for me. So you mentioned there that the microvascular risk factors as a consequence of diabetes are more closely aligned with poor glycemic control versus the macrovascular risk factors, which are more a consequence of the broader cardiovascular risk factors that the person has. So why don't we go through those complications now, starting with the microvascular complications?
So the first thing to say, John, is I suppose with all this fantastic chronic disease management that we're seeing now, we certainly hope that people living with type 2 diabetes are going to be seeing reduced risk of all of those complications. And, you're absolutely right. We have the microvascular complications and the macrovascular complications. Just considering for a moment the microvascular complications, I think this is something where in practice, we are looking out for them in our CDM reviews anyway. So these are things such as diabetes-related eye disease, such as diabetic retinopathy. We have diabetic foot disease, neuropathy, and then we're thinking about our nephropathy, our diabetes-related nephropathy, which leads on to chronic kidney disease. And what I'd say to people kind of out there is just we can really add value in keeping an eye out for these things. So signposting the diabetic retina screen program to our patients, making sure that they're aware of it, they've signed up for it and they're going for their retina screen. So that's something which can really be of benefit. That foot examination, which usually our practice nursing colleagues are doing a fantastic job of doing. So we know actually from the third report into the CDM program that 98% of people attending for CDM reviews are actually getting their foot examination done, which is fantastic. And then I suppose the other thing, and this is something which is worth maybe considering for a practice audit, is making sure that we're getting both a renal profile and a urine albumin creatinine ratio on all of our people coming in for their diabetes reviews, so that we can pick up if somebody has developed diabetic nephropathy and chronic kidney disease. Now, we won't labour the kind of management of all of these things extensively today, but if you're interested in any of these topics, we do have in the appendix of the GPU, we have got the grading system for the diabetic foot, if you're interested to read a little bit more. And we've also got a hyperlink within the GPU to the other fantastic GPU on chronic kidney disease. And we do also have a table in the GPU which signposts to medication safety for diabetes-related medications in people living with chronic kidney disease. So if people are interested to take a look, they might want to have a look at those sections in the GPU.
And it really highlights again, Lisa, just what a mine of information that these general practice updates are. And no more than the other conversations I've had with other authors, what we're trying to pull out in our conversation today is really just, you might call it a highlights reel of some of the key features that might be helpful to general practitioners in their day-to-day clinical practice, but certainly it is worth downloading the general practice update itself and having a look through for all of the additional material that's there too. So thanks for that. That's the microvascular complications. Could you turn to the macrovascular complications, please?
Yeah, so I suppose the macrovascular complications, we're really thinking there about our management of things like atherosclerotic cardiovascular disease. And I think this really pulls together a lot of the things that we've already signposted from earlier in the podcast. So considering not only management of glycemic control, but also considering all cardiovascular risk factors. And then it is worth also thinking that this is a group of people who can benefit from that cardiorenal protection. So when we have a person with type 2 diabetes and they have atherosclerotic cardiovascular disease, thinking about adding in some cardiorenal protection for them.
Before we move on from complications and review, it strikes me that, as most of the GPs listening will, I'm sure, agree, reviewing patients in settings such as a CDM review can be really beneficial to them, because as GPs, we tend to keep a kind of a big picture view of other conditions that they may also be developing. And of course, we're not just looking at diabetes in isolation. We're also screening for some of these other conditions that may be appearing on the horizon.
Yeah, you're absolutely right, John. And I suppose your point highlights how valuable it is to have our CDM conditions looked after within general practice by general practice teams. We know that GP teams are great at looking at the big picture. We also know that when it comes to the majority of our CDM conditions, probably as you mentioned off air, with asthma being the exception, many of the risk factors are shared. So, the likes of smoking, hyperlipidemia, hypertension, many of these are shared risk factors for several of our chronic diseases. So when we're seeing somebody with one chronic disease, I think something we're really good at is keeping an eye out for all of the other ones. One that's probably worthwhile mentioning, because we haven't talked a huge amount about it so far, is there's quite a big overlap between heart failure and type 2 diabetes. And this is maybe something which is less publicized than the likes of type 2 diabetes and atherosclerotic cardiovascular disease. So diabetes is a risk factor for developing heart failure in the future, and having diabetes puts a person at twofold increased risk of developing heart failure in the future. It's also worth noting, actually, that at the registration visit for a person with type 2 diabetes, a BNP is one of the included blood tests. And the reason for that is because of the common coexistence of these two conditions. And then the other thing just to mention is in one of the appendixes that we have within the GPU is the recommended investigations for the CDM program. So it's just if people are interested, if they find that they're not quite sure what blood test is required and when. We don't want to be doing too few blood tests. We absolutely don't want to be doing too many. So that's worth a look as well. But you're absolutely right. There's a huge overlap between our chronic conditions, and the massive benefit of having these reviews in general practice is we're really taking both an individualized and a multi-morbidity approach to care.
Great. And I suppose the overlap reflects the overlap in the podcast episodes as well, Lisa, and that if you are interested in learning more about heart failure, Eamon O'Shea has put together a really good episode that gives a complete overview of heart failure. And Eamon and David McConaughey also have a very nice episode on implementing opportunistic case finding and primary prevention in your practice, as well as CDM, so that we capture more of these patients upstream and control the modifiable risk factors before they develop into chronic disease. So there's plenty there for people to get stuck into if they're interested, as you said. Okay, I really appreciate your time and expertise on all matters diabetes, Lisa, but before I let you go, I must ask you about some ideas for audit that listeners might like to hear about for their own practice.
Yes, I suppose we all know that on a yearly basis we have to submit either our audit or a quality improvement project. And I have started to really enjoy doing these projects. I think they're a great opportunity to reflect on your practice. And if there is an area of your practice that you're particularly interested in, they're a great opportunity just to take a deeper dive into something and make a change that will benefit your colleagues and your patients. Sometimes the hard thing can be to decide what to do, because you could literally audit anything under the sun. So what we have tried to do with GPU is on page 17, we've got a list of different audit suggestions that people could pick from if they are interested in doing a diabetes related audit. One of my favorite ones is probably having a look at whether or not people are considering an individualized target HbA1c for people living with type 2 diabetes. I think that's a really nice audit because it brings in many aspects of high quality individualized diabetes care. So that's a nice one. Another one, I suppose, we spoke in particular in episode 1 of the podcast about how putting knowledge is power, really, when it comes to people living with type 2 diabetes. So maybe doing an audit of the referral rates for people with type 2 diabetes and checking whether they've been referred on for a structured diabetes education and management program, that Discover Diabetes program. It's quite an easy one to do. And then another one, I suppose, we know that living with type 2 diabetes does carry a higher risk of infectious illnesses. So having a look at your flu vaccine rates and your pneumococcal vaccine rates amongst your patients living with type 2 diabetes and having a think about how to maximize them. That's another audit, not too onerous, and really can be of benefit both to the practice and to people living with type 2 diabetes.
And I should just say, Lisa, that you've picked out 3 there from a list of 10. So there's something for everyone. And as you said, you could get several years worth of audits for the years to come just from that list alone. And it's all clinically relevant, straightforward, and something that could actually improve your practice on behalf of this patient cohort.
And I'm sure everybody wants to do 10 diabetes audits, John. I'm sure that's at the top of everybody's list of things to do.
Many thanks again to Dr. Lisa Devine for speaking to me today. And don't forget to check the show notes for chapter markers and links to resources. If you've any comments or feedback on today's show, or indeed suggestions for future episodes, please let us know. You can contact us at podcast@icgp.ie. And that's it for today. Thanks again for listening, and until next time, take care.